Good morning, everyone. I'd like to thank Josh for a brilliant presentation. Thank you, Josh. It's really a pleasure to be here, and I really want to thank the DRC Li Ka-shing Foundation and the province on Guangdong for allowing us to present to you what we do. We're medial cancer screening, and what we see here is the map of cancer incidence worldwide. Cancer is big, and our hope is to help in fighting to reduce the morbidity and mortality from cancer by applying big data approaches to provide individuals with personalized probability for having cancer. And cancer is lethal. Cancer is very lethal. If we look at statistics from the World Health Organization, we can see that in China, cancer accounts for more than 50%. This is actually the #1 killer. And we can see that there are 4 cancers that account for more than 50% of the incidence. We're talking about the digestive tract cancer, we're talking about the lung cancer, and it's more than 50% of the mortality. If we look deeper, we can actually see here that although the incidence is high, it is comparable to what we see in other countries. Yet, the mortality rate is high. Now, creating a nation approach or nationwide approach to fight this is complex. It is very complex in a country with the size of China and with the other challenges that this country is facing. But this calls for innovation. This is calling for innovation in policy. Because 2 million people a year are dying from cancer in China. And this is what we hope to help with. We hope to provide algorithmic models that use existing standard data that is ubiquitously available to be able to create scores for individuals that might be at elevated risk for cancer and that would be encouraged to be further diagnosed. And then potentially there might be an intervention that would change their prognosis. And by this, we might be helping to reduce the morbidity and mortality from cancer. We call this approach e-screening. And the idea is to take very simple, cheap blood tests, existing ones. We're not developing a new biomarker or a genomic approach, which is very expensive to bring to the market. We want to take the simple tests, we want to combine this with gender, age, potentially some other environmental parameters, and feed this into different algorithms that we create, eventually providing indicators for different types of cancer. Starting with colorectal cancer, we're already working on lung cancers, and there are additional cancers that we're working on. Where eventually the idea is to point out those individuals that are at elevated risk. And for them, we would recommend further investigations. For the others, we would simply suggest to follow the guidelines. Now, the first product that we're promoting is for colorectal cancer. We call it ME-score. The idea is to take a simple blood count. This is probably the cheapest and the simplest test that is being done. It's done worldwide. It's standard. It's available in each and every lab. And it's known that for colorectal cancer, intestinal bleeding and anemia are associated with the disease. So this is kind of the biological motivation. But when physicians look at hemoglobin levels, they would only look at those that are extremely low, and only then they would recommend people to get investigated. And what we believe is that using computational approaches, we might be able to detect those subtle variations of the parameters. These subtle variations that occur over time, these subtle variations that, or the relationships between the different parameters. So we'd be able to indicate these patterns as well as those that are already without the norm. And by using this, we can actually provide a score that is as simple as a hemoglobin reading, but is much more effective. So we would look at existing results, indicate people that are at elevated risk, recommend for those that are above the threshold or are at risk to get a colonoscopy, which is the diagnostic test. This is the gold standard today. And for the others, follow the guidelines, whatever the guidelines are, in that specific area. Now, we've built this model on a very large data set coming from primary care, coming from Israeli population. We validated on a blinded set, and then revalidated on a different UK population, which actually is a different population. This population has different health services, different racial composition. It's behaving differently, yet we got comparable results. And one of the advantages of the score is the fact that it is continuous. So you can actually decide what is the cutoff point. What is the point where you decide that someone is at risk and you want to encourage that individual to get further investigated? And when you do this, when you have this option, this is also an economical tool. Because if you have many resources to go and investigate and deal with a large population, that's fine. You can deal more cases. Of course, the expense is that you're spending more money on getting them tested. On the other hand, if you want to start smart, you want to start with a low investment, you can really go to a high cutoff point. For example, as we see here, if you set the bar high, eventually those that you indicate would have 30 times more the risk than the average person. We've been validating this worldwide because it is important for us to see that it's stable, it works with different populations, and we're doing this in Europe, we're doing it in the US, and we want to do it in Asia Pacific. Currently, the status is that this product is cleared for use in the European market. It's been approved by the Ministry of Health in Israel as a medical device, and we've started discussions with the FDA in the US in order to clear it as a medical device in the US. To sum up the value proposition, for one, we believe that this is a simple and cheap method that could actually act and help us to increase the detection rates. It can be adjunct to current methods, or it can be a method to start with. We've built models to see the cost effectiveness. These models run all kinds of Markov simulations, and eventually we look at two parameters. One is, do we help to increase life expectancy? And the second one, what is the additional investment that we have to do in order to get this added life expectancy? So this is kind of a cost effectiveness analysis, and what we see is that if we use this strategy, either in a situation where there's no screening at all, or even when there is a screening approach and we simply use it as an adjunct model, first, we can increase life expectancy. Of course, these are models. We have to still prove it, but this will take time. The second thing is that not only that we don't have to add additional investment, but over the time, this actually saves costs. So this is a cost-saving approach, and this approach has been already proven in multiple publications worldwide, so that screening pays off. The other thing is that we really hope to be able to provide a model that is using the same set of data to provide scores for multiple cancers. So just imagine that a primary care physician would actually would send an individual to the very simplest test and would get 2, 3, 4 indications whether that individual might be at elevated risk for cancer. One of the most important things with cancer reduction of the morbidity is to detect these cancers at early stage. When you detect a cancer at early stage, the chances for that individual to survive 5 years after the detection is over 90%. With advancement of medical treatment today, even for stage 2 or 3, it's still high. For colorectal cancer, currently, even 70% of those that are detected at stage 3 can survive the 5 years. But stage 4 is lethal. So we need to detect cancer early, and we've seen from the data that we can detect a significant number of early stages. Sorry, the last one, not least, is we believe that by using this approach, it's using a very simple and cheap blood test and providing these scores to primary care physician, this could be applied widely. This could be provided to every primary care physician to help out this fight against cancer. What we hope to do here is to be able to validate this model. We'd like to collaborate with data holders, data owners, to see that this model works well, also in population in China. And ideally, if there's a province that is looking to pilot out cancer screening, we'd love to take opportunity in this pilot, whether it's for colorectal cancer, whether it is for lung cancer. I want to thank you very much, and I hope you enjoy the rest of the day. Thank you.
Thank you very much, Rory.